John, we can't hear you, I think. I can't hear you.
That's because I wasn't.
We can hear you. Okay.
Because uncharacteristically, I wasn't saying anything.
Good to see you.
Good to see you. We have a few minutes. Were there any questions anyone had on the presentation yesterday that I could pick up on before we start the new case? Yes, I see a hand. Samantha.
Oh, sorry. I was just saying hi, actually. I just joined. So.
Hi.
I have a question, John.
Great.
I wonder, that's not a question. I wonder if you can describe more, because the when you do the intervention, when you start the head-on collision, I think I missed what's the different signals that made you go over to head-on collision.
Sure.
It went fast for me. Yeah.
So we go to head-on collision when the patient sees the resistance, sees the price of the resistance, does it anyway, and seems to be satisfied or takes pleasure in the resistance. So when the patient first uses the resistance, the patient doesn't know she's resisting. She doesn't see it. So that's why we have that phase of resistance identification. So our first step is patient is using a resistance. She doesn't know she's using it. She doesn't know it has a price. She doesn't even know she keeps on doing it. So we first start helping the patient see the resistance. And once she sees the resistance and she sees the price, then we challenge the resistance. So since she sees the resistance when she does it, and she sees the price, then we ask, so what can we do about that, do you think? What are you going to do about that? Which it would be challenging the resistance. Now, if she sees the resistance and sees the price, and you continue to challenge the resistance, then you realize, wait a second, she sees the resistance. She sees the price. And when I ask what she's going to do differently, she keeps using that resistance. That's when we realize, oh gosh, the patient seems comfortable with it. She keeps doing what she knows is hurting her. So at that point, we would say the patient's identified with resistance because she knows she's doing it. She sees the price and she's doing it anyway. So at that point, then we would do the head-on collision to point out that her resistance is actually going to defeat her wish to get well.
What was the specific sign at this patient that you can that told you that? Because theoretically I know.
Right. So what were right? Well, remember when I pointed out after a number of times, she would herself point out that she would nod, and in fact she said, "Oh, I went away." She knew she was going away. Right. And she would nod when I pointed out. The price was clear to her. I pointed out another times, but we saw that even though I pointed out to her and she saw the price, she kept doing it. And then when I did a little head-on collision, just a little one, and then I challenged her, she kind of shrugged her shoulder and said, well, that's it. Right. And then realized, oh, you see it, you see what you're doing, and it's causing it. Now, there's another set of secret signs. So when a patient resists you initially and they don't see it, you'll know that they're resisting because the sign has stopped. You do pressure to feeling, and if a patient's warding off feelings, the patient sighs. When you do pressure to feeling and the patient starts to resist you, sign stops. When you start to identify their resistance, oftentimes sign starts up again, and you keep identifying the price, sign starts up. But once you keep identifying the resistance and the price and sign stops, then you go to challenge. And when you challenge the resistance, usually sign will kind of start up again. And as you're challenging resistance, when sign stops, that means the resistance has risen even more, and that's a sign to go to head-on collision. So paying attention to signaling is a very important aspect. Unconscious signaling is a very important cue. A lot of times we're doing the challenge, we don't realize actually my challenges are not mobilizing sign, it may mean that I actually need to go to head-on collision. Yeah. Well, thank you for that question, Bonnie. So today we're going to be looking at a very different case. This is another case, a patient who's in repression. Now, the patient I showed yesterday, she started out in repression, and then we began to realize with building capacity, she was highly resistant with repression. Now we're going to see a patient whose repression is far more severe, and at points she hits thresholds of fragility. So this is a lower capacity fragile patient in terms of character structure. So my work is going to be even more graded in terms of how I work with her. So maybe to get started, we'll just go to the new PowerPoint. And okay, here we go. And okay. Now I've labeled this patient as traumatized fragile. She actually has access to repression, and she starts out in repression, but at a certain threshold, she'll start to go into splitting and projection. So you're going to be seeing how I'm working with repression and with splitting projection as we go over that particular threshold. So here we go. Okay, so in the initial session I had with her, this was a chronically depressed patient. She'd been depressed for like 30 years, suffering from very severe migraine headaches. And all the treatments she'd had for depression, all the treatments she'd had for migraine headaches, excuse me, none of them work. So there was no response to any therapy or medication she'd had. So by the beginning of treatment, she was really on disability because she just couldn't function on her job due to her headaches, severe fatigue, and angry outbursts. In her history, there was a history of chronic physical and verbal abuse by her parents and her grandparents. So she had been verbally abused and beaten by her parents and by her grandparents. She's married and no children and has not had sex in a number of years. And having sex is not a goal for her. So that also gives you an idea of how little pleasure there is in her life. So in session 1, it became clear to me that this patient's anxiety was in cognitive perceptual disruption, smooth muscles, massive self-attack, and splitting. So with the rise of feelings, this patient easily feels devalued by others, or she devalues others. And so I would learn about how she devalued her previous therapists and devalued doctors, devalued students of hers. So for her, what happens is that when she would become angry, she would split and regard someone as all bad, and then she could act out her rage toward these all bad, devalued figures at work. So in other words, she could split and view someone as all bad, and then that would justify her acting out in angry outbursts. So here we are now with session 2 that I'm going to show today. So I'm going to show you sessions 2 and 3, and you're going to be seeing subtleties of graded format. So in the second session we're going to look at today, we're going to be taking a look at how do we stop regressions in session? How do we get anxiety back into the striated muscles? How do we build a consensus on what causes her suffering? And as Amir was saying, how do we build her self-observing capacity? See, I can observe a lot, but that doesn't do her any good, right? If I observe and she doesn't, nothing happens. So what are kinds of interventions I can do that can build her ability to observe herself? And of course, the big question, how can we build her affect tolerance so that she can tolerate a higher level of feelings before she goes into repression? Tolerate a higher level of feelings before she goes into splitting and projection. So with that entry, and I think this is, is that right? Is that number 4? Yeah. Okay, so now that's my whole lecture. We're going to go straight to video. Feel free to stop me at different points. This is a very complex case. And the reason it's complex is the more disturbed the patient, oftentimes the more complex the case is, the more difficult it is. So I'm really going to be spending a lot of time just in the micro analysis of what she's doing, how I'm responding. So if there's any part of that micro analysis that's not clear to you, please let me know, because these patients are difficult because we have trouble assessing these microscopic little moments that we've got to work with. So here we go.